So hi everyone, my name is Andreanne Fortin. I'm a dietitian, and today thanks for joining us today. It's 1 p.m. So today we're going to present, me and Roxane, the presentation called Weight Loss and Type 1 Diabetes. The presentation is going to be 45 minutes, and we encourage you to add your question to the Q&A section on the platform here. We're going to try to answer it throughout the presentation, but we're going to allow time at the end also if there's more questions. So first of all, I'm going to present myself. My name is Andreanne Fortin. I'm a dietitian and certified diabetes educator. I work at the IRCM clinic in Montreal with mainly Dr. Rémi Rabassa-Loret as an endocrinologist. We follow approximately 700 to 800 patients with type 1 diabetes on insulin pump or injections. And I'm also a dietitian at the IRCM clinic in dyslipidemia, hypertension, and rare and genetic disease. I'm going to ask Roxane to present herself.
Good afternoon. My name is Roxane. I am a kinesiologist and a member of the research team at IRCM. We work mostly with type 1 diabetes, and subject is more exercise.
So like I said before, we're going to encourage you to ask your question. The presentation is really for to give you some tools and tips, but we want also to help you as much as we can. So you can just type your answer in the Q&A section. So the summary for today, first of all, I'm going to start for the first part of the discussion, and then Roxane is going to join us at the middle for the exercise part, and I'm going to join back at the end. So first of all, we're going to talk about the best weight concept, but mostly also overweight and type 1 diabetes. What do we know now? But also identify, possible causes of that excess weight gain, and to find strategies to take action and to try to tackle this situation. So the best weight concept is something that I'm going to discuss throughout the discussion, but first of all, I want to make a conscious. First of all, with type 1 diabetes, for you as patient, and there's a lot of attention, we ask you to have a lot of attention on food, especially because we ask you to do carb counting to adjust the insulin based on what you eat, on the amount of carbs you eat. So you constantly have to count or evaluate how many carbs you eat to adjust your insulin to have better glycemic control. There's also the issue of hypoglycemia. So you have to correct or prevent hypoglycemia by eating carbs or adjusting your insulin, but mostly eating carbs. So that leads a lot of patients to losing sight of dietary balance. The pleasure eating is often something less feasible, because there's always that thinking about carb counting. How does it going to affect my glycemia? And recognizing satiety signals, so hunger and satiety, is sometimes more difficult. There's also some stigmatizing comments that I hear as a healthcare professional, that my patients tell me. For example, you shouldn't eat this because you live with type 1 diabetes. You have type 1 because you ate too much sugar when you were young, or just comments about your weight, like good comments because you lost some weight. These are stigmatizing comments, and the type 1 registry better did another webinar maybe 1 or 2 weeks ago on that subject alone. I encourage you to go see that video, which is really helpful, give you some tips, but this video is only in French if it's okay with you. So that leads to psychological consequences, because there's always that in your mind. And those psychological consequences are shown in research, because there's a high risk of developing eating disorder in people living with type 1 diabetes. Approximately 30% of female and 10% of male adolescents have some kind of eating disorder with type 1 diabetes. We often see also diabulimia, which is a type 1, the presence of type 1 diabetes, and an eating disorder, mainly due to omission of insulin. As a healthcare professional or as family members, what are the warning signs we see that trigger me the thinking that maybe my patient could have a tendency of eating disorder? So an excessive preoccupation on weight, body image, mood change, depression, fatigue, hiding, eating food by hiding, or extreme physical activity, unhealthy relationship with insulin, so missing insulin doses, or other hospitalization, ketoacidosis. In terms of glycemia, unexplained hyperglycemia, abnormal high A1C without obvious causes, missed or skipped insulin, reduced food portion. So these are all triggers for me to maybe gruger or search a bit more if there is a tendency of eating disorder. What do we do if we think that maybe that's could be something that's an issue with us? First of all, it's good to think that it has a significant impact on the body for sure, but it's really to talk to your healthcare team and ask for help. There's ANEB, Anorexia and Bulimia Quebec, which is a good resource that you see the information here. So the key points for today and overall, these are points that changes we try to aim, but it's not something that can be done tomorrow. It's a lifelong battle, I would say. So if I go that, so first of all, the changes we wanted to make it for yourself and not for your family members, your boyfriend, your colleagues. Beware of social pressure, because there's a lot of social pressure, family, but also the media. And don't use weight as the only indicator for your health. I'm going to discuss that more afterwards. Love yourself, so accept your body as it is. Don't punish yourself and remove the guilt. Like I said, these are points that it's a lifelong battle for sure for many of you. Eating, having a pleasure of eating, balanced eating, and don't restrain yourself too much and remove the guilt, because starving or restricting yourself doesn't work. Like I said, we try in the past couple of years or months, we go away from the concept of ideal or healthy weight, and we move more towards the concept of best weight. So what's the concept of best weight? The best weight is different for everyone. So it's not a number that the whole population should aim. It's the weight that you're able to maintain while having healthy lifestyle and having the healthiest and happiest life. In 2020, so just before the pandemic, there was some Obesity Canada guidelines that just were released, new guidelines. So the BMI is for sure something that you probably have heard of. It's your weight and your size, and we classify your BMI on healthy weight, obesity, or excess weight or obesity, or underweight. It's been used by healthcare professionals for many years, but because it's easy to calculate, but it lacks precision on the risk of complication. You may have heard a person that was classified as obese, but his weight is, he has a healthy lifestyle, good health parameters, but it's mostly muscle, for example. So we try to go away from BMI, and we try to include more and more the waist circumference, because it's an added information on body composition and cardiometabolic risk. Because underneath your waist, that's all your vital organs are. So if those organs are submerged or circled with fat, they function less well. So it's an added indicator. Like once again, it's easy to calculate, but it's really to make more an emphasis rather than numbers, more on health parameters like blood pressure, cholesterol, rather than the weight on the balance. Other recommendation that we as health professionals try to go for, it's really to ask permission to talk about your weight with you. rather than just talking to it. So is it okay if today we discuss your weight? Just as an open question. What we want is really to achieve sustainable and realistic goals based on your individual values, preferences, and making those goals personalized to you rather than eat less, move more, the classic easy tools. We want you to give you more personalized goals that you can achieve on the long term. We go away from diets and we go towards a non-diet approach. I'm going to talk to you more about later. And obesity was classified as a chronic disease, so it's something that we want follow up on the long term. So what do we know about type 1 diabetes and overweight? Research showed that an excess weight increases the risk of cardiovascular disease and has an impact on mental health. Related to type 1 diabetes especially, so excess weight in type 1 diabetes often shows an increased insulin doses needed so increased insulin resistance, higher risk of high blood pressure, high cholesterol. So these were problems that we saw before in type 2 diabetes. But more and more with the weight that has increased in type 1 diabetes, but like the general population, we see more and more those problems with type 1 diabetes also. So that's why we talk more about double diabetes. So type 1 diabetes, but with features that were classified as a type 2 diabetes more before, like insulin resistance. So what are the causes of those excess weight? So for the general population, for sure, as a dietitian, also unbalanced diet. So diet high in sugar, fat, a lot of sugary drinks, hypercaloric has an impact on your weight. But the causes are not always and not only food. That's important. There's a lot of other causes that could explain an excess weight. Stress, overweight, sleeping problem, sedentary lifestyle that Roxane's going to talk to you more afterwards. Hormonal problems or changes, for example, thyroid, hypo or hyperthyroidism, period of hormonal changes throughout the lifespan. For example, adolescence or menopause. Menopause is a period that the metabolism tends to decrease and the weight tends to increase. Some treatments, some medication like antidepressant, cortisol also. Genetic factors or environmental factors. For example, do we have access to healthy food? Do we have access to sport facilities, or we have to take our car? And we tend to be more sedentary on that part. So these are causes for the general population. If we add specific causes to the type 1 diabetes, hypoglycemia. So if there's too much hypoglycemia, when you have a hypoglycemia episode, you have to correct or prevent that hypoglycemia with carbs. So these carbs has an impact on caloric intake for sure. So that these are calories that your boyfriend, for example, that doesn't have diabetes, doesn't have to take. And hypoglycemia could be a barrier to physical activity and could lead to people tending to be more sedentary. Food also. Like I said, when you have type 1 diabetes, as a dietitian, we recommend to do carb counting to adjust your insulin based on the amount of carbs you eat. So this is a complex task that needs a lot of calculation. So some of my patients try to go more towards processed or packaged foods because they have a food label and it's easier for them to count because all the information is already there. However, those processed food are also ultra processed and they tend to have more fat and less fiber, for example, and more sugar. Treatment also, they could be some weight fluctuation with the administration of insulin, but if your insulin is well adjusted, that shouldn't be a problem. So these are causes that adds to your weight. So is it harder to lose weight when you have type 1 diabetes? I would say yes, because these factors are factors that doesn't talk to a person that doesn't have diabetes. So now that we identify potential causes, what could be the strategies? First of all, food. So as a dietitian, I'm going to talk to you about that. So first of all, there's no specific diet for type 1 diabetes or no specific macronutrient distribution that should be aimed. So we don't aim at a precise amount of carbs, protein, or lipid, or an amount of calories. The advices are the same as the general population. Before the pandemic, maybe 3-4 years ago, there's the new Canada food guide that was launched. And the main part of that food guide is the balance plate that you see the image here. So the balance plate is really an image that I really love to use as an image, like I said, and it's really shows the proportion of what we want in our plate. For example, half of the plate is filled with vegetables, quarter of the plate is protein, and a quarter of the plate is starch. The starchy part is the main foods that have carbohydrate in your diet. So if you see here, the quarter of the plate with starchy food is a lot of whole grain foods rich in fiber. For protein section, we want to try to choose lean proteins also. So what we want is to prioritize low glycemic index food that are high in fiber and less processed as possible, and foods that are rich in nutrients like fruits, vegetables, lean protein, whole grain, nuts, for example. And we'll want to limit processed foods with added sugar, sweetened beverage. The good word here is to limit rather than avoid, because there's no forbidden food in type 1 diabetes. The key is really variety and pleasure. Two words I often use is moderation and frequency. So not to limit any food, but once we have those foods, try to have it in smaller portion and not having regularly. The regularity in carbohydrate intake, meal timing, and spacing helps for glycemic control, but also weight. Because if we tend to skip a meal, sometimes what it does is that you're really hungry or you crave for food because you're hungry, and you tend to snack, or you tend at the other meal to eat a larger quantity and fast. And if skipping meal increases your risk of hypoglycemia because your medication is not well adjusted. Hypoglycemia, once again, you need to correct that hypoglycemia with sugar, so it has an impact on your weight also. Eating behavior. So what we want is really eating slowly. You probably heard of it before, but we want to aim at eating in around 20 to 30 minutes because that's the amount of time that your brain needs to have to receive the signal from your stomach that you ate enough. So if you eat too fast, you may have the tendency to serve yourself a second plate, but you're already full or you already ate enough. And trying to have a pleasure in eating, because eating happens 3-4 times a day. So if it's always a stress and not a pleasure, it's not something that we want. It's really the concept that we hear more and more. It's intuitive eating. The next webinar on Better, that's going to be March 23rd. It's going to be on that subject particularly. So I'm not going to talk to you more a lot about that today. And the last thing, is that more accurate carbohydrate counting and adequate insulin doses improves glycemic control and limits weight fluctuations. Like I said, there's no specific diet in type 1 diabetes, but there's some dietary patterns that have shown benefits in type 1 and type 2 diabetes on weight and cardiovascular risk. Some of them include Mediterranean diet, vegetarian or vegan diet, DASH diet, which was initially designed for hypertension, or diet based on legumes, fruits, vegetables, and nuts. However, a caution here is that we want to avoid restrictive eating patterns, like the yo-yo, which leads to a yo-yo effect. So if we have a too restricted diet, so you may lose some weight fast, but what we see is that you regain the weight and sometimes even more. So once again, we want to find a dietary pattern, or eating habits that you're able to maintain on long term, but also that's in line with your values and preferences. So that's a resume here. Next part, alcohol in that food section. So recommendation for alcohol in type 1 diabetes are the same as the general population. For women, it would be two drinks per day for a maximum of 10 per week. And for men, it's 3 per day for a maximum of 15 per week. And next, alcohol, and just also to remember that alcohol increases the risk of hypoglycemia. And an excess alcohol intakes, it's liquid calories, so it can have an impact on your weight also. Another cause of weight gain in type 1 diabetes is hypoglycemia. So frequency of hypoglycemia, more and more, maybe your health profession, your healthcare team, if you're using a CGM, we're talking more and more about percentage of time in hypoglycemia. And we aim at less than 4% of time throughout the day, 4% of the day in hypoglycemia, which leads to less than an hour per day in hypoglycemia. If the frequency is higher than that, we want to identify potential causes and adjust treatment as needed, because too much hypoglycemia has an impact on your diabetes control, but also on the amount of treatment you need and the amount of calories. Because the treatment recommended is the rule that you probably heard of many years ago, which was designed many years ago, It's to take 15 grams of simple sugar, wait 15 minutes, and if the hypoglycemia is corrected, you're good. If not, try to another 15 grams after 15 minutes. Taking more than 15 grams, if not necessary, leads to an excess caloric intake and possibly a rebound hyperglycemia. However, like I said, this rule is was designed many years ago and was never reevaluated a lot. So that's why, for example, at our clinic, at the IRCM clinic, we're doing right now a research project to see if that rule could be changed or more adjusted to the value, to your value of blood sugar and more personalized targets. In terms of hypoglycemia, physical activity also could have an impact. Physical activity could be, hypoglycemia could be a limit to practice physical activity, but also could increases your risk of hypoglycemia. So these are some points that Roxane's going to talk to you more after. So what are people doing right now? In the better registry that you're in right now, the average of hypoglycemia was 1 day out of 2 that patients had an hypoglycemia, and more than 50% had treated their hypoglycemia with greater than 20 grams of carbs. Was 20 grams of carbs or more necessary? We don't have the values, but if it's not necessary, for sure it could have an impact on your weight. Another study was done 7 years ago, an observational study, at our clinic also, and showed that the average carb intake for hypoglycemia treatment was 32 grams. Once again, was 32 grams necessary to correct that hypoglycemia? We don't have the values, but if it's not necessary and 15 grams would have been enough, that excess amount of carbs could have an impact on rebound hyperglycemia, but also on caloric intake. So I'm going to see for Roxane for that physical activity part right now.
Yeah, so in the next slide, I will talk about physical activity as a strategy for weight management. Also, we'll talk about the benefits of physical activity, even if you don't obtain weight loss in short or medium term. So here on the right are the Canadian physical activity guidelines for individuals with type 1 diabetes compared to general population. activity guidelines, there is no difference between the people with or without type 1 diabetes. The recommendation is, as you can see, 150 minutes of aerobic physical activity per week. You need to do it at moderate to vigorous aerobic intensity. You also can accumulate these 150 minutes by doing at least 10 minutes at a time. So for example, you can do 30 minutes 5 times per week, and you reach the recommendation. You also need to have no more than 2 consecutive days without physical activity, because we want to limit the sedentarity period. So it's better to just do a little each day than just doing a really long day of physical activity on the Sunday, for example. The question is, who follows these recommendations? Maybe you find them excessive, maybe you don't. For example, before the pandemic in 2016, 2017, only 16 to 17% of Canadian adults follow these recommendations. So it's really not that much. In comparison, 42% of adults who are registered in the Better program purport to follow this recommendation. So you are better, but I think they have space for improvement. So what is in the literature the kind of exercise you need to privilege if your main objective is weight loss? Aerobic training exercise results in greater overall weight loss and resistance training, but not necessarily a greater fat loss. I explained, as you can see, the advantage of resistance training is that it helps you reduce body fat while maintaining lean body mass. So it's not necessarily a greater weight loss overall, but you can keep more of your lean body mass if you do it so. In terms of weight loss and glycemic management, the HIIT training, which is defined by high intensity interval training, is interesting because this type of exercise reduces the risk of hypoglycemia and generally affect less the glycemia compared to the other type of physical activity. Because it has a high intensity and a lower duration, you cannot do it like 2 hours of high intensity, it's not possible. The glycemia tends to be more stable or increase a little depending on their circumstances. Finally, you can privilege some type of the exercise I said before, but there's no unique way to do physical activity as a strategy of weight management. If you choose an activity that you enjoy, you will be more inclined to keep your motivation in the long term and keep your physical activity more frequently. What limits physical activity? We did a questionnaire in our clinic to patients with type 1 diabetes, and these are the four barriers for patients. We have fear of hypoglycemia, low level of physical fitness, work schedule, and loss of control of diabetes. To be more active, you need to address this barrier that you have and find a solution to limit their impact in your physical activity. For example, in the case of fear of hypoglycemia, you can plan strategy to decrease the risk of hypoglycemia during and after your activity. Also, maybe the more simple way is to choose the kind of physical activity that lower the risk of hypoglycemia, like HIIT training. Another example is the low level of physical fitness. You don't need to increase your volume of activity drastically. It's better to increase progressively and starting with exercise with lower risk of injury, for example, than go to subscribe to a fitness class 6 times a week when you before did very little exercise. You need to increase progressively, it is important, and pay attention to your recuperation as well. On the opposite side, what is that promotes physical activity? We have 4 points here. The first one is strategy to reduce hypo risk. For example, if the exercise is planned, you can be ahead and reduce your insulin and take the meal before. If you have a pump, for example, you can reduce also your basal insulin rate 90 minutes before your activity, or use the physical activity mode if it is available in your pump. Instead of insulin management, you can also take a snack with carbohydrates before, during, or after the activity, depending what kind of activity you're doing, what intensity, and what is your glycemic value at the time. So it's many factors, but it's why it needs to be personalized. Social support is also really important. If you have a friend, a family member, or a partner, it will be easier to commit to a new activity and doing it more frequently. It can be also a good motivational support, and maybe it's what you need to be more active. If you don't necessarily need a group to practice physical activity, maybe you need more supervision or help to learn new activities. A professional supervision, as a kinesiologist, for example, or a class, can help you learn new exercise and have feedback while you're doing it. It can help you achieve and set up also your objectives. Finally, if you plan your activity in your schedule, you probably will be able to control more your glycemia and keep your habits in your schedules, instead of just say, I will doing it the next week and then the week after and the week after. So, myth or reality? Does eating carbohydrate during physical activity affect weight loss? Maybe you think it's true, but fortunately it's false. And I will show you why in the next slide. But in the meantime, for those among you who want to take less carbohydrate during exercise, you can, as I said before, choose types of workout or activities that tend to maintain and or increase blood sugar levels. For example, you can do strength exercise. You can also do interval training in aerobic activity like swimming, running, cycling, soccer, and etc. We did a study in our research lab. We compared 2 carbohydrate strategies to prevent hypoglycemia during 1 hour of bike exercise. The recommendation of sugar intake was 0.5 grams per kilogram of body weight of our participants, taken just before or progressively during exercise. The conclusion was that both strategies help to prevent hypoglycemia during exercise. Also, the energy expenditure, as you can see, was way higher than the energy intake. So it's really interesting to use physical activity as a strategy. For this kind of exercise, it's a good strategy to prevent hypoglycemia, especially if the exercise is not planned or if you didn't do any insulin adjustment before. Finally, exercise is a great way to increase your daily energy expense as a way to manage your weight. But even if you don't have a weight loss immediately, you will have many benefits from including more physical activity in your daily life. Doing exercise improves the lipid profile, quality of life, self-esteem, and increase healthy years. It also decreases insulin requirement, waist circumference, and risk of cardiovascular disease. So I hope I convince you to do more physical activity in the next few days.
So the 2 other possible treatments that I'm going to discuss to end off. So the first one is medication, the GLP-1 receptor agonist. So it's an incretin. So GLP-1 is secreted naturally by your stomach, by your intestine, sorry, when you eat. So what it does, it increases satiety, decreases gastric emptying, and increases insulin while decreasing glucagon. So that's why it was developed an agonist that could increase that secretion, which could have an impact on your weight. The benefits of those GLP-1 receptor agonists has an impact by decreasing A1C without increasing the risk of hypoglycemia. It also decreases insulin doses. On your weight, there's a decrease in weight based on study between 3 to 6 kilograms, and also improvement in cardiovascular risk, especially in type 2 diabetes with type 2 diabetes patient with cardiovascular disease. However, like I said, since it has an impact on gastric emptying, there could be some gastrointestinal side effects. The more common are nausea, vomiting, diarrhea, and constipation. However, the main part in today that I want to say is that there is no indication right now by Health Canada, for people living with type 1 diabetes, and it's not covered by the RAMQ. There's also, like I said, side effects that are are common. So mainly nausea. So that's why if it started, we start at the low dose and gradually increases the dose to limit those side effects. So these GLP-1 receptor agonists are on injectable or oral, and it could be taking, depending on the molecule, twice a day or once a week. For example, there is one that's an injection once a week that's called Ozempic. And it's for people that have an excess weight and that have don't reach those glycemic targets and that have a cardiovascular disease or at risk of cardiovascular disease. But once again, it's not covered by the RAMQ, and it's not indicated by Health Canada for type 1 diabetes. So it's something that you can discuss with your endocrinologist, but just remember those two parts. The last treatment possible is something that's probably heard of. It's bariatric surgery. It's been present for many years. There's different types of surgery, but all those surgeries lead to weight loss and improvement in obesity-related comorbidities like hypertension, dyslipidemia, and renal function. There's also a decrease in insulin requirements, but the effect on A1C is less clear based on the studies. There's also an improvement in quality of life because there's a weight loss. However, it remains a surgery, so there's risk of surgical complication like any other surgery, but the risk of surgical complication is not greater than people without diabetes that go through that surgery. There's also but with type 1 diabetes, there's an increased risk of glycemic variabilities. After surgery, there's a lot of hypoglycemia. Almost 3/4 of patients have hypoglycemia immediately after the surgery. But there's also risk of severe hypo or ketoacidosis on the other part after surgery if the insulin is not adjusted. There's also risk of nutritional deficiencies. Another challenge of that surgery is the accessibility. So it's there's depending on the center, there could be many years of waiting list. And also, like I said, there's a change in image with that weight loss, and the change in image could have an impact on your vision of yourself or body image. And we often recommend and advise for psychological follow-up afterwards because you need to accept that new body image. But the accessibility, once again, for that psychological follow-up is variable, and that it can be long. For type 1 diabetes and bariatric surgery, there's a few studies right now, and the studies done are in few participants. So that's why we see more bariatric surgery in type 2 diabetes, but it's something with type 1 diabetes that could be done also. So for conclusion for today, as healthcare professional, but mostly you as patient, there's a lot of guidelines, a lot of recommendations that come from everyone, from the media, from your healthcare team, from your family members, your entourage. And it's not always easy to follow those recommendations on the long term. What's important today, the key message is, as type 1 diabetes, you may have greater challenges for weight loss, but what we want is to go away gradually from the weight on balance and to go more towards optimizing lifestyle habits and health, and to see health benefits with or without weight loss. And really, in terms of eating, it's really to conserve a pleasure of eating and not follow that restricted diet, because eating is something that comes many times throughout the day. And we want to make some changes with you as a healthcare professional that you could maintain on the long term, but based on your values and preferences. I don't know if Roxane want to add something about physical activity, particularly for conclusion.
I think the same goes for physical activity. You need to do it for pleasure and also to have a goal in the long term, not just, for example, for 3 months and then you stop and you restart maybe a few months later.
And you want to do it for yourself and not for everyone else. Exactly. That's another thing to maintain it on the long term. So that's for today. I don't know if you have any questions. We have some time to answer your question. And I'm just going to go while we wait for questions. So like I said, the next webinar is a month ago, March 23rd, and it's going to be especially on intuitive eating and type 1 diabetes. It's going to be done by another dietitian, Claudia Hull, which is a dietitian, but has also type 1 diabetes. So we're going to wait maybe 2-3 minutes. If you have some questions, we're here for you. Okay, so we have a question here. So what's the DASH diet? Like I said, DASH diet was a diet that was designed, first of all, for hypertension. So DASH stands for Dietary Approach to Stop Hypertension. But the tips on the DASH diet looks a lot like Mediterranean diet. So there's a lot of fruits, vegetables, whole grains, nuts, legumes. So I have another question. What's your thoughts on no sugar drinks? So like a diet, I would probably like diet soft drinks. So what are my thoughts? For sure, if a patient is drinking a lot of sugary drinks, like a regular diet Pepsi, I would prefer just not having those drinks. But if it's if the only option for you is to go towards those options, that's better, because for sure there's no calories. But the amount of false sugar or like additives could have an impact on many aspects. For example, some patients could increase the craving for sugary foods, or could have an impact on gastrointestinal problems. So if, first of all, I would try to cut it down or gradually decrease it if it's not possible, or maybe gradually cutting with no diet options to gradually decrease your consumption. Another questions, diet would where you cut out the carbs and sugar. Like I said, there's no dietary approach. What we want is really to avoid a yo-yo diet or restricted diet. So I wouldn't go towards that restrictive diet, but for sure, gradually decreasing sugary products or added sugar products are a good option, but not limiting any foods. No food is prohibited. It's all in terms of moderation and frequency. And I think we answered that question. And there was another question, yeah, which we answered already. So maybe one last question, if there's, will you be sharing the recording? So yes, we're gonna send, you're gonna receive, if you're, because you're registered on the registry, you're gonna receive by email the link, but it's gonna be available online also on the Better registry. Okay. So thank you all for being here this afternoon. And I hope this webinar was helpful for you. And we encourage you to assist at other webinars. And we're gonna say good afternoon for all of you.
Yeah, thank you for attending and good afternoon.
Bye.
Bye.